Good afternoon, Chairman, Co-Chairman, and our audience. My topic today is update anatomy and biomechanics of the posterior cruciate ligament and their surgical implication. Okay, let's start with the PCL anatomy. PCL is the largest intra-articular ligament in the knee, which originates on the anterolateral aspect of the medial femoral condyle and insert onto the PCL facet. It's made up of two distinct but inseparable bundles named by their position within the femoral footprint. Center of each bundle are 12 millimeters apart. The average length of PCL is 32 to 38 millimeters, and average width is 11 to 13 millimeters. The cross-sectional area are increased from tibia to the femur, with 2 times larger at the femoral attachment. It composes of two bundles, anterolateral bundle and posteromedial bundle. The larger anterolateral bundle is attached to the roof of the notch. Center of the PCL bundle can be identified by reference with the arthroscopic bony landmark. For the anterolateral bundle, it located at 7.4 millimeter from the trochanter point, 7.9 millimeter from the articular cartilage, and 11 millimeter from the medial arch point. The smaller posteromedial bundle attaches to the side wall between anterior and posterior meniscofemoral ligament with area range from 60 to 90 square millimeters. Posteromedial bundle is located at 8.6 millimeter posterior to the distal articular cartilage. The meniscofemoral ligament attached to anterior and posterior to the femur and act as secondary restraint to posterior tibial translation. For tibial footprint, both bundles attach to a depression between the tibial plateau at 1 centimeter below the joint line called PCL facet, and the insertion roughly about 50% across the width of the tibial plateau, 6 to 7 millimeter proximal to shallow ledge champagne glass drop-off. Meniscofemoral ligament run from the posterior horn of the lateral meniscus to lateral aspect of medial femoral condyle. Their names were based on the location in relation to the PCL, which anterior meniscofemoral ligament, also known as ligament of Humphrey, and posterior meniscofemoral ligament, also known as ligament of Rysberg. To identify both bundles, the incidence is roughly around 70%. The neurovascular bundle lies within the popliteal fossa close to the PCL, with the popliteal artery lies 7 to 10 millimeters from posterior border of PCL, with the max distance is at 100-degree knee flexion. There is an anterior septum between posterior capsule and PCL. By releasing this septum, it will increase the distance of popliteal artery approximately around 1 centimeter. Let's turn into the PCL biomechanics. The main function of the PCL are to provide restraint against posterior tibial translation at all flexion angle and limit rotation beyond 90 degrees of knee flexion. This ligament is not only the largest intra-articular ligament, but also the strongest due to its high tensile strength. The classic PCL tension pattern were believed to be functioned separately, with posteromedial bundle tight in extension and anterolateral bundle were tight in flexion. However, in the recent in vivo study shown that both bundles to play a larger synergistic role in flexion. Papanagri et al. Found that both bundles to be tight in flexion and lax in extension. Similarly to Wang et al. Also corroborate the finding that both bundles serve a greater role in flexion, supporting that PCL is primarily restrained to posterior translation of the knee, especially at high flexion angle, and also found that popliteus muscle may act as a secondary restraint to the posterior translation in PCL deficient knee. This slide shows the synergistic function of both bundles in resisting posterior tibial translation. In case of the isolated injury to each bundle, the other bundle will provide the synergistic function to restrain the posterior tibial translation. But if two bundles are injured, the posterior tibial translation will increase dramatically. The role of PCL in rotational control of the knee is still unclear. Many contradictory studies published in the literature. However, it believed that it may act as a secondary stabilizer to rotational forces, particularly at high degree of knee flexion. For the joint contact pressure, although patient may tolerate the true PCL deficient knee, this deficiency results in abnormal load and kinematic during functional activities. Sky-High et al. Revealed that 52% increase in mean contact pressure in the medial compartment and increased contact pressure in patellofemoral joint from 23 to 28 Pascal after sectioning of the PCL. The present data regarding the strength in the PCL deficient knee is mixed. To date, there is some evidence that PCL has a minor role in proprioception of the knee. The loss of proprioception has been postulated to be a potential etiology leading to medial compartment and patellofemoral joint degeneration. However, no study demonstrating that reconstruction of the PCL could restore this function. For the meniscofemoral ligament biomechanics, focal studies show that transection of the meniscofemoral ligament will increase in femorotibial contact pressure. Gupta study also shown that meniscofemoral ligament supports PCL in limit AP laxity by providing similar load capability to posterior fiber bundle of the PCL. Isolating injury to PCL without injury to meniscofemoral ligament, the posterior tibial translation is reduced. Surgical implication. By the anatomical point of view, the reconstruct graft should be large enough to withstand the high tensile load. And with robust blood supply of the PCL, with high healing potential capacity. In some cases, with the posterior tibial translation less than 5 millimeters, conservative treatment in this population may be a good option. And with its large femoral footprint, double bundle reconstruction may simulate more identical to native PCL property. The review of case series from Frank Noyes showed that incorrect tunnel placement is one of the major causes of the PCL failure. The frequent error where the tibial tunnel is too proximal and femoral tunnel is too posterior. Therefore, accurate femoral tunnel placement by precisely reference the intraoperative landmark is crucial to reduce the risk of the PCL failure. Although the tibial tunnel is not directly correlated with PCL failure, however, with its risky position, iatrogenic injury to the medial meniscus and popliteal vessel may occur. In order to reduce the iatrogenic vascular injury, please keep the knee in flexion during tibial tunnel reaming and using the large end curettage to cover the guide tip while reaming. Using transeptal technique for better visualization and keep the vessel away from the reamer. And at the end of the reaming process, please do it by your hand. For the clinical relevance, the true clinical relevance after PCL reconstruction is unclear. Some studies report similar activity level, but some others demonstrate limitation and decreased performance in PCL deficient knee. Several others also note the correlation between posterior laxity and decrease in functional score. And with increased contact pressure in PCL deficient knee, untreated PCL may potentially increase the risk of osteoarthritis. For the meniscofemoral ligament, according to its biomechanics, transectional of the meniscofemoral ligament can increase femorotibial contact pressure. Therefore, whenever possible, meniscofemoral ligament and remnant of the PCL should be preserved during PCL reconstruction. Take-home message. Due to large femoral footprint, hence argument for double bundle reconstruction of the PCL to recreate resemble kinematic profile. And please do not underestimate the importance of the meniscofemoral ligament. Preserve it whenever possible. Medial meniscus root and the popliteal artery are close to the PCL tibial insertion. Careful when during the PCL tunnel. and utilize arthroscopic and radiographic landmark to ensure anatomic placement of the graft. Thank you for your attention.
Thank you very much.